This is Emergency Medicine Cases EM Quick Hits podcast, and I'm your host, Dr. Anton Hellman.
EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for general information and educational purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician. Unless stated otherwise, the opinions expressed by the hosts or guests are made in their individual capacity, not on behalf of the Institute nor Medicine Cases. First, a word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring a fair distribution of shifts while integrating circadian-friendly rhythm recovery time into its methodology. Less sleep deprivation means I can be a better EM doc on shift and still have energy for life outside the hospital. Check out metricade.com/EM cases to make your schedule fair and improve your sleep. This episode is brought to you by Easy Resus, the resuscitation assistant. This amazing app has drug dosing, equipment size calculation, treatment algorithms, all in under 3 clicks. Rapid access to life-saving critical info in a user-friendly interface. Try the app for free with the promo code EMCases or visit easyresus.com/EMCases. That's easyresus.com/EMCASES. It's an absolute pleasure to have Dr. Isaac Bogosh, infectious disease specialist at University Health Network in Toronto. We've spoken together at a bunch of conferences. I'm excited to say that he has agreed to be on the next EM Cases Summit. He's a fantastic speaker. And I just have one question for him, and that is, what's the latest on tick-borne illnesses?
Ticks. Everyone's favorite and least favorite topic. Favorite because it's interesting, least favorite because they're kind of a pain in the ass and they're spreading and they're gross and nobody wants a tick bite. I'm going to be geographically biased here. We're sitting in Toronto, and this is going to be a bit of a Canadian approach, but in general, we're having less cold and shorter winters, which is allowing ticks to survive and thrive in more northern latitudes. And we are seeing more tick-transmitted illnesses in Canada. The obvious one that everybody knows of is Lyme. In 2024, based on the Public Health Agency of Canada's data, there were roughly 5,000 cases of Lyme diagnosed in the country. This is a gross underestimate. And I think anywhere where Lyme is endemic, the reported cases is a gross underestimate. It has such protean symptoms that we're missing a lot of cases, but we are definitely missing a lot of cases here in Canada. It's not just Lyme. And I think Canadian physicians and also the Canadian general public really needs to be aware of other emerging tick-borne illnesses. In New England and in the northern United States, they're aware of them. But of course, these ticks don't respect political boundaries. And we are seeing cases of anaplasmosis. And here's another one for you, babesiosis in Canada as well. They are grossly underdiagnosed because A, the general public doesn't know about them, and B, clinicians don't know about them. Not hard to diagnose, not hard to treat. You just have to be aware of them. And the key thing here is that the same ticks that transmit Lyme also transmit anaplasmosis and babesiosis. And in highly endemic areas like in New England, anywhere from 10 to 20% of cases of Lyme will have a co-infection with either anaplasmosis or babesiosis. Again, not hard to diagnose, not hard to treat. You just got to think about it. You can send blood work to your provincial or state public health laboratory. They'll do the appropriate tests. And again, the treatment is very straightforward. People can get pretty sick from them. I think this is a bit of a failure to consider on our behalf because we're just not thinking about them. I think if you've made the clinical decision to order a Lyme test, you should also be ordering either anaplasma and babesia as well.
Most of the patients I see in the emergency department, they come in because they just had a tick bite. And there might be a tick there, and we pull it out, and we give them 200 milligrams of doxycycline and send them on their way. Then there's the patient who has, a target lesion or some target lesion equivalent, and then we'll put them on doxy for longer, a couple of weeks. When do you suggest that emergency physicians send for Lyme and send for these 2 other bugs?
Okay, so if someone has the target rash, like the erythema migrans, And I agree with you completely. You treat those people for Lyme. We know that Lyme serology can be negative in these early stages, and you might just have the rash and maybe some additional compatible symptoms. So treatment is completely appropriate. I still order Lyme serology when people present like that because I'm thinking ahead. Test for Lyme when someone presents with erythema migrans. It doesn't have to be positive to still be Lyme, but if it is positive, it helps you rule in and you have diagnostic closure, which might prevent you from ordering 1,000 other tests. If it's negative, it doesn't necessarily answer the question, is it Lyme or not? But you've already made the decision to treat for Lyme. And if the patient is unwell for any other reason and returns to medical care, we know they've had a negative Lyme test a week ago. You would repeat that test when they present. If the Lyme test is still negative, it probably isn't Lyme. It's probably something else, and you need to expand your differential diagnosis. If it is positive for Lyme, you've got a case of Lyme with a positive serology, and you made the right clinical decision to treat.
Got it. That brings us to when would you treat for the two other bugs? What were they called again?
Anaplasmosis and babesiosis.
Anaplasmosis and babesiosis. When would you test for those?
So I think you're going to see a huge change in clinical practice. I'm testing for these all the time. And when I'm ordering a Lyme serology, I'm also ordering anaplasma and babesia testing as well. What's interesting is when you're treating someone for Lyme with, for example, doxycycline, that also treats anaplasmosis. So how many cases of anaplasmosis are being treated unknowingly in the province of Ontario or elsewhere in Canada when people are treating Lyme? Probably a lot. Babesia has a different treatment. Babesia is fascinating, and I know this is an emergency medicine podcast, and I'm an infectious diseases nerd, but Babesia, from a microorganism standpoint, from a diagnosis standpoint, from a treatment standpoint, it's malaria. It's amazing. It's like a protozoa. The diagnostic tests are the same. The treatment is the same. Like you're using anti-malarial drugs to treat Babesia. It's pretty fascinating.
Wow. So that sounds like that's the reason why we should send for Babesia, because the treatment is different.
The treatment is definitely different.
So for the other one, you're going to be treating it with your doxy anyway.
You absolutely are. But you still want to know. Because people with anaplasmosis get really sick. Here's a cool clinical clue.
Okay.
Someone in New England, we're not really savvy enough yet here in Canada, but in New England, when people present with, fever and a leukopenia. Leukopenia is a pretty common phenomenon associated with anaplasmosis. It's one of the clues of anaplasmosis. Yeah, it's not that specific or sensitive, but you definitely see a leukopenia associated with it, which resolves after treatment with doxycycline. So, if someone comes in, they have systemic symptoms, they may or may not have a rash compatible with Lyme, but they do have systemic symptoms. In this case, you're going to test for Lyme. And you should also test for anaplasmosis and babesiosis. You have systemic symptoms and a history of a tick bite, or you're coming in from tick country and you have non-localizing febrile illness, you should test for anaplasmosis and babesiosis. Obviously, if someone has, cough, sputum, fever, you're thinking pneumonia. This is, that is a localizing febrile illness. But a non-localizing febrile illness in the context of a tick bite or coming in from tick country, yeah, you should be testing for those 3 infections.
Okay. And then for babesiosis, it's like malaria. You're not going to be treating it with doxy. It's actually totally different treatment. So could you just tell us a little bit about what that treatment is like?
The treatment is, again, very similar to how we treat malaria. Many treatments would involve, for example, azithromycin and atovaquone. Atovaquone's an anti-malarial drug that's commonly used. So the treatment's very different, for example, than treating anaplasmosis or Lyme.
Great. Okay. So that's some great stuff about updating us on Lyme. We need to be aware of this anaplasmosis, which is treated basically the same as Lyme, and babesiosis, which is not treated like Lyme. It's a tick-borne illness that's very similar to malaria. We should just think about it as malaria, and we need to send off for it specifically in those patients that have a febrile illness that we can't figure out what's going on if they've been in tick country, and especially if they've had a history of a tick bite. Got it.
One of the tricky things about emergency medicine is we often don't get to see our patients in follow-up to see how they fare upon leaving the emergency department. Moreover, many procedural techniques we use have been passed down through generations of medical training on the basis of this is how we've always done it. sometimes without good clinical evidence that it's the best way of doing things. This is why I'm interested in literature that describes outcomes of our patients after they've undergone procedures in the emergency room. A great example of this is for nailbed repair. In this episode, I'm going to share a focused review on nailbed repairs that could change your practice. In general, emergency physicians are expected to manage simple nailbed injuries. For complex injuries, including open fracture, nailbed or nail matrix avulsion, or nail matrix injury, you should consult specialist services. Injuries to the nailbed and nail matrix can result in permanent deformity of the nail, which has important cosmetic and functional consequences. For this reason, meticulous repair of nailbed lacerations has long been recommended, with the goal of nailbed repair being to minimize long-term cosmetic and functional complications from the injury. However, we don't actually have a great evidence base on what exactly is the best practice for managing nailbed injuries, and our existing standard of care is largely based on decades of expert opinion. So the standard approach to a nailbed injury that most of us were taught is to use a digital nerve block to anesthetize the finger, apply a finger tourniquet, gently remove the nail from the nail bed, clean and irrigate the wound with lots of saline, use fine dissolving sutures to reapproximate any laceration, and then clean and trim the nail and reinsert it into its anatomic position and secure it in place with stitches. The theoretical rationale for suturing the nail back in place is that it will act as a biologic splint, holding the nail bed and nail fold in anatomic position to encourage appropriate healing. The repaired fingertip is then dressed with a non-adherent dressing. This procedure should be done meticulously and using the fewest sutures possible to reapproximate the tissues. If you are not gentle and precise, your suturing could injure the nail bed. And during the process of removing and reinserting the nail, you could definitely cause further damage to the nail, bed, or matrix. If you tie your sutures too tight, you could strangulate the tissue and impair wound healing. With these considerations in mind, some studies have evaluated alternative approaches to repairing the nail bed. The first batch of studies I'll talk about use tissue adhesive glue instead of sutures, both to reapproximate the nailbed laceration and to secure the fingernail back in place. Most of the studies looking at using skin glue for nailbed repair are not RCTs. They're actually small case series or retrospective studies describing the skin glue technique and showing good clinical outcomes in their patients. However, we do have one single center RCT in 2008 which randomized 40 consecutive patients to either Dermabond skin glue or suture repair. This study followed up with the patients over 6 months and found that cosmetic and functional results were not significantly different between the suture or skin glue groups. The study also found that skin glue repair was significantly faster, with an average time of 9.5 minutes versus 27.8 minutes in the suture group. Another notable study on this topic is a single-center retrospective cohort published in 2020, which looked at 74 repairs, 36 with glue and 38 with sutures, and again found no statistical difference in cosmetic or functional outcomes, but a significantly faster time to repair with skin glue. The overall literature is pretty sparse. After all, there's no big nailbed industry funding large RCTs here. But the limited RCT and observational evidence we do have suggests that using skin glue to repair the nail bed and secure the nail back in place is just as effective as using sutures and much faster. But skin glue versus sutures is not the only clinical question when it comes to nail bed repair. The one nail bed study that stands above the rest is a multi-center RCT from the UK published in the British Journal of Surgery in 2023 called the Nailbed Injury Analysis Trial, which they amusingly abbreviated as the NINJA trial. This RCT of pediatric nailbed injuries managed to enroll 451 patients. The NINJA trial had a different clinical question. What if, after we do a standard repair of a nailbed laceration with dissolving sutures, we simply discarded the fingernail instead of securing it back in place? 224 children were assigned to the nail discarded group, and 227 were assigned to the nail replaced group. And after the repair, both were dressed with the same non-adherent dressing. Infection rates and cosmetic outcomes at 4 to 12 months of total follow-up were not statistically different between the nail discarded group and the nail replaced group. And though this is a pediatric study, there's a smaller RCT of 50 patients published in 2024, which looked at the same clinical question in adults and had similar results. All in all, this evidence suggests that after doing a standard nail bed repair with sutures, it would be reasonable to discard the nail rather than secure it back in place. All right, let's sum things up. Though we have an overall dearth of literature to definitively suggest any one approach is best, there are two main takeaways from the literature that could change your practice when it comes to nail bed repairs. First, consider using skin glue rather than sutures for nail bed repairs. The evidence we do have suggests it's much faster with no significant difference in outcomes. And number two, if you're repairing the laceration, consider discarding the nail rather than suturing it back in place. The evidence again suggests there's no difference in outcomes. The broader question is, which nail bed injuries even benefit from repair compared to observation or simple decompression with nail trephination? When should we be removing intact fingernails to evaluate and assess nail bed injuries in the first place? There's not a clear answer in the literature, and it remains a controversial topic with lots of practice variation between different providers. We have evidence from small studies that for simple nail bed injuries where the nail is still intact, it's just as effective to leave the nail in place rather than removing it to perform a nail bed repair. Hopefully in the future, we're going to see studies evaluating even more conservative approaches for uncomplicated nail bed injuries. It's just going to take a long time for RCT level evidence to emerge without any big nail bed industry to fund these studies.
That was Dr. Matthew MacArthur. Thanks so much, Matt. Excellent review. One thing he touched on that I wanted to dig into a bit deeper is when to consider nail bed repair in the first place. So these are just some of the factors to consider. A subungual hematoma of more than 50% of the nail surface is a pretty good predictor of an underlying nail bed laceration. But if the margins are perfectly intact, you probably don't need to remove the nail to explore for a potential nail bed repair. In general, consider removing the nail and exploring for potential nail bed repair if there's a deep laceration of the proximal or lateral nail fold, if the nail plate is obviously mobile, lifted, or split, or if there's a significantly displaced phalanx fracture. If in doubt, consult plastics or arrange a tight plastics follow-up and explain to the patient that the nail may grow back with the deformity. All right, next up, we have a new guest to EM Cases that I met at ISEM in Montreal this year after she gave this great talk on pediatric ECG interpretation. Dr. Kathleen Stefanos is a pediatric EM doc at the University of Maryland Medical Center in Baltimore and a passionate educator. Take it away, Dr. Stefanos. But before we hear about pediatric ECG interpretation, a quick word from one of our sponsors, Easy Recess. Easy Recess is thrilled to announce that they are now available for institutional access. In addition to providing the app for all employees in your organization, this means access to exclusive features like printable protocols with calculated medication doses, customizable content to fit your local protocols and practices, access to Easy Recess on computers via the web-based version, and much, much more. To learn more, visit the institutional license section at easyrecess.com. And as always, you can download Easy Recess and use the promo code EMCases, that's EMCASES, one word, to get your 2-month free trial on an individual subscription.
For all of us who work in adult emergency departments, we are so accustomed to being handed adult EKGs. It seems like every 10, 15 seconds, we glance at them, we run through their algorithms, and we move right along. But pediatric EKGs usually demand a pause. Children's EKGs just don't look right, or at least they look different than the adult EKGs. And things that might alarm us in adults may be totally normal in kids. The stakes are a little bit higher, and I think that gives us all a little bit more concern when we look at these EKGs versus when we look at an adult EKG. But hopefully by the end of this session, you're going to feel much more confident interpreting pediatric EKGs. So let's dive right in. First, you need to make sure you get the best possible EKG. I take a 3-step approach to this: soothe, snip, and slow. So soothing means we got to calm our patient down. For me, usually that means food, as long as they're not NPO, to make sure that they are the most calm they can possibly be. In a neonate, we might need to swaddle them after we apply leads to make them a little bit more calm. We might have to reassure a toddler, have them stick the stickers on themselves so that they can be helpful, or simply distract them from what's going on. Next, don't be afraid to cut the lead longitudinally, because think about those small chests. It can be really hard to fit the EKG leads perfectly on a smaller chest, so sometimes we just need to cut them in order to get them on the smaller chest. And remember, we're dealing with a much smaller heart. The neonatal heart is almost the size of a walnut, and so it's a lot harder to get a really good EKG, so you might need to snip them to get them in the right position. Finally, pediatric rhythms are so much faster than adults. Consider slowing them down using your machine. Heart rates are higher due to the small size of the heart, the decreased stroke volume, and decreased blood volume. Because of this, you may need to slow down your machine. So take some time and look at your EKG machine and see how you can slow it down when you're looking at it. Remember, always repeat if there's a concern. This patient population does tend to have more errors, possibly due to a little bit more artifact as they move, or just less frequency and comfort with placing the leads on these smaller bodies. Once we have that perfect EKG, we're going to approach it similarly to any other EKG. Let's not make it more difficult on ourselves. Just go through this like you would with an adult. Remember, as a neonate transitions to extrauterine life, their heart goes from a right ventricular predominance to a left ventricular predominance, which is going to be evident as we approach this EKG. So starting with the rate is obviously dependent on the age of your patient. Bradycardia is notably concerning for children and most often is associated with respiratory causes, so hypoxia may lead to that bradycardia. But we also have to consider some of those rarer things that are more isolated to that younger patient population, such as congenital lupus or thyroid disorders. As we move into rhythm, just like in adults, patients' rhythm should be sinus. An upright P in 1, 2, and AVF is expected, while in adults a downgoing T and P in lead 1 often means arm lead reversal. In children, we do have to remember that some of these children may have dextrocardia as the cause of that specific ectopic rhythm if they've never been evaluated before, so just something to consider. But most of the time, it still means limb lead reversal. Sinus arrhythmia is incredibly common. These hearts are much more compliant. They are much more responsive to respiratory variability. So a sinus arrhythmia really doesn't give me much concern when I look at an EKG. But I have had people come up to me and say, oh my gosh, I think this patient's in AFib. And it's really just that profound sinus arrhythmia. That's a normal variation in children. PACs and PVCs may occur in these children as well. And oftentimes you'll see an ectopically conducted atrial beat if you're looking at those EKGs. SVT is the most common arrhythmia that we're going to see and need to intervene on. Again, look for those P waves. This is a really great time to slow down your EKG on your machine because you might just need to slow it down to find the P waves if they're really tachycardic. Even with most previously reported ventricular tachycardias in children, the ultimate diagnosis still ends up being supraventricular tachycardia. So remember that this is, by and large, the most common thing you're going to see that's abnormal on a pediatric EKG. As we look into axis, children will have a right axis until about 6 months of age. After this time, the axis moves left until they develop a normal axis by the time they can typically sit or stand, so around 6 months to 1 year of age. This is seen in the upright nature of the AVF. Intervals are typically very similar to adults. And while we do vary based on age with charts available for age-related norms, you can certainly find them anywhere online if you need to go looking. We can still relatively consider a QT longer than 450 to be abnormal, with considerations for intervention when it's over 500 milliseconds. Importantly, in neonates, the QTC may be slightly more prolonged, with up to 490 being in the normal range. If you're looking at your QRS complex and notice that it's greater than 120 milliseconds, this should be concerning for pre-excitation, particularly in conjunction with a short PR. Though, depending upon the situation, you could also consider electrolyte abnormalities or bundle branch block or ventricular tachycardia. Fortunately, all of those are much less common in pediatrics. Now we look at the waves themselves. We start with Q waves. Oftentimes in the adult patient population, we're worried about Q waves as an indicator of a prior infarct. However, in children, they're often mistaken for abnormal because up until age 3, you can have completely normal inferior and lateral Q waves. They have to be narrow. They have to be less than 8 millimeters in size in order to qualify as being normal. As they age, however, they do gradually disappear, and persistent Q waves can be concerning for hypertrophic cardiomyopathy. We start screening for this around age 10 to 12, though some are advocating for earlier evaluation of this. Q waves in these patient populations are concerning. Additionally, a deep Q wave isolated to AVL may be indicative of an anomalous left coronary artery from the pulmonary artery, also known as Al-Kappa. This is a really concerning finding, though fortunately quite rare. As we move on to the rest of the QRS complex, it's completely normal to see an RSR prime pattern in V1. This may look like an incomplete right bundle branch block, but it is normal as long as the R prime is not consistently larger than the R wave, and the R wave is dominant in leads V1 through V3. As long as we're finding those findings, completely normal to see this. When we evaluate these patients, we're really assessing for ventricular hypertrophy. That's why we're looking at that QRS complex. So when we're looking, we're going to focus on lead V1 for right ventricular hypertrophy. Remember, neonates initially have a predominant right-sided circulation, so a pure R wave or an upright T in a neonate can be normal. But as they get older, if you see a T wave persisting past week 1 of life or a pure R wave after 6 months in V1, this is concerning for right ventricular hypertrophy. If the R prime is larger than the R wave, this is also concerning for right ventricular hypertrophy. These are subtle findings, but really important to identify in pediatric patients. For left ventricular hypertrophy, we can look all the way to the other side of our precordial leads and look at V6. If we see the R wave reaching and touching the baseline of V5, this should be our sign that we are concerned for left ventricular hypertrophy. Both of these findings, in the correct clinical context, should be discussed with the cardiologist, particularly if they are new findings. And last but not least, the T wave, probably the thing I get called about the most. While we focus on these in adults for ischemia, the tricky T wave often gets mistaken in children for something way more sinister. T waves should be upright in all leads in a neonate, but as the child becomes older, the T waves flip. And a T wave inversion is completely normal in V1 through 3. Completely normal. While in an adult, we're all scared about that LAD occlusion that we're going to potentially miss if we don't pay attention to these inversions in V2 and 3. They are normal in children. So when do we need to be concerned about flipped T waves? Well, children's EKGs with inferior or lateral T wave inversions, these may indicate ischemia. Or if isolated lateral V5 and 6, they actually may be concerning for left ventricular hypertrophy. And similar to adults, if we're looking at V1 or V2 and we're seeing a coved or a saddleback appearance to the T waves, that could be concerning for Brugada syndrome. Fortunately, all of those other findings are quite rare. And that's the pediatric EKG. While intimidating, we can approach these just as we would in an adult with a systematic approach. Remember, the pediatric physiology really contributes to what we are seeing as the heart pressures increase over time on the left side of the heart. Make sure you're giving significant pause if we're seeing bradycardia. Remember, if you're seeing a dysrhythmia that you feel like you need to act upon, it's probably supraventricular tachycardia. Normal findings that are isolated to children are going to be those T-wave inversions in V1 through 3, the RS-R prime pattern in V1, and those Q waves before the age of 3 in the inferior leads. We're going to be more concerned with the bradycardia, or signs of persistent right-sided heart findings. And V1 will tell us about right ventricular hypertrophy, while V6 is going to be where we look for left ventricular hypertrophy. With practice and familiarity with normal childhood variants, pediatric EKGs become very approachable. You can approach them with the same framework that you use for an adult. Just keep in mind that age-specific physiology, and you've got this.
Thank you so much, Dr. Stefan. We now have the mighty return of Sim Master, Dr. Sean Segerin. He's going to take a close look at closed-loop communication and explain how to do it right, how to do it effectively.
Closed-loop communication. Everyone's heard of it. It's an ACLS, ATLS, and every SEM debrief. We all nod, and we all say that we do it. But after facilitating hundreds of simulations, here's what I've learned. Most teams think they're closing the loop when they're really just checking a box. Let me show you what I mean. I was running a trauma sim at a rural hospital. 1 doc, 3 nurses. Patient came in with multiple injuries, hypotensive, free fluid on fast, and clearly not protecting their airway. The physician called out, "Let's get 100 of ketamine." A nurse nodded and walked off. Another was prepping the airway equipment. There was no pause, there was no confirmation, there was no real exchange. 30 seconds later, ketamine's in. The physician turned, surprised. Wait, I didn't say to give it. Suddenly the room froze. No one was on the same page. And this is exactly where the concept of closed-loop communication gets misunderstood. Because it's not about repeating an order. It's about building clarity at every step. Here's what it should look like. First, the order is directed, not shouted into the void, but given to a specific person. Can you draw up 100 milligrams of ketamine? Then that person confirms, drawing up 100 of ketamine. When the medication is ready, they then circle back. Ketamine's ready. Do you want me to give it? The physician gives the green light. Yes, give it now. The nurse calls it out. 100 of ketamine in, and the recorder closes the loop. Ketamine given at 14:32. That's not just clean communication. It's team-wide clarity. That's how you build what we call a shared mental model. Everyone knows what just happened. Everyone knows where we are, and everyone knows what is coming next. It's not about having the same job. It's about having the same picture. When that happens, people stop asking what's going on, and then they start anticipating what has to happen next. But here's the thing that no one tells you. This is not easy. It feels unnatural at first. Everyone is focused on their own task. The nurse is pushing meds. The doc is thinking 2 steps ahead. Someone else is trying to troubleshoot the monitor. And in that chaos, remembering how to communicate clearly doesn't always come naturally. It takes practice. When I run full days of simulations, it takes usually 3 to 4 full cases before teams really start to get it right. Not because they don't know what closed loop communication means, but because doing it under pressure takes repetition. And honestly, you don't need every step to be perfect. Even if you just hit a few of them, directed orders, clear confirmations, and calling things out loud to the group, you will see fewer mistakes. You'll feel the room sync up, and the whole team will start to share a common picture of the case. That is what makes high-functioning teams feel effortless. So the next time you're in a recess, try building the full loop. Because if you're unsure whether the ketamine's gone in, or even worse, it already has without anyone else knowing, you didn't close the loop. You just hoped it would close itself. And in a recess, hope isn't a strategy.
And now a word from one of our sponsors, Echo Health. If you've ever guessed what you heard through a stethoscope, you're not alone. Detecting a new aortic regurg murmur to help you pick up that acute aortic dissection with a regular stethoscope can be really hard in the noisy ED environment. Thank goodness for Echo Health. Echo combines the stethoscope you already know with enhanced audio and advanced AI to help you detect heart and lung conditions earlier and with more confidence. Echo's digital stethoscope amplifies heart and lung sounds up to 40 times, and noise cancellation cuts out distractions. Unlock murmur and AFib detection powered by Echo AI, along with sound recording, sharing, and more for earlier diagnoses and seamless collaboration. Backed by 4 million heart sounds and 8 FDA clearances for devices and AI algorithms, those who use Echo are 2 times more likely to detect heart disease. If you want to give your patients the highest quality care, I encourage you to join 600,000 healthcare professionals already using Echo. I trust Echo so much that I worked with their team to create a special offer just for our listeners. Right now, you can get $50 off plus a free customizable chest piece cover at echohealth.com/EMC. Your purchase is HSA and FSA eligible and may qualify for CME reimbursement. Plus, Echo guarantees you'll detect heart and lung conditions more confidently. If you don't, return it for a full refund. Go to echohealth.com/EMC for $50 off plus a free chest piece cover. That's ekohealth.com/EMC. All right, I reached out to Britt Long to ask him if he could do a quick hit on a topic that I never really ever felt comfortable with myself, partly because the hospital I work at doesn't have a dialysis unit, so I don't see a ton of these patients. So you probably guessed it already. We're going to talk about end-stage renal disease. So here's Britt Long to demystify that patient with failing kidneys.
One type of patient that we need to know how to manage is the patient with end-stage renal disease who's on dialysis. In today's quick hit segment, we're going to cover end-stage renal disease, dialysis, and what you really need to know. This is an incredibly common condition. Just in the US, there are over 500,000 patients on dialysis. There are 2 different major types of dialysis, and the complications can vary based on the specific type. Hemodialysis is the most common form. About 7% of patients receive peritoneal dialysis, and about 30% of patients will receive a functional renal transplant. So, how does dialysis work? Hemodialysis uses an external filter as a replacement for the kidney that removes solutes and excess fluid. Most patients receive 3 sessions per week that last about 3 to 4 hours each. Some centers use these high-flux machines that can shorten the session. Obviously, patients need some sort of vascular access. The optimal access is an AV fistula, but this does need a couple months before it's mature. A synthetic graft is another option, and it can be used within a week of placement, but these have higher rates of infection and clotting. The third option is a central venous catheter. This can be cuffed or tunneled versus non-tunneled. Unfortunately, these have even higher rates of infection and clotting. Peritoneal dialysis is different. This uses the peritoneal membrane for that blood dialysate interface. The patient basically instills fluid containing dextrose or some other solution in different concentrations using a catheter that enters the abdominal cavity. Then the osmotic difference between the blood and the instilled dialysate is used to remove excess fluid and solutes. Patients can use an ambulatory regimen with 4 to 6 exchange sessions during the day where that fluid is left in the abdomen for several hours and then it's removed. Another method is to use a machine cycler that exchanges the peritoneal fluid during the night with another exchange during the afternoon. The issue with both of these types of dialysis, and really end-stage renal disease in general, is that there are a number of complications. First is the risk of infection. These patients are immunocompromised, and plus, they have an access site. Cardiovascular disease is another major issue in these patients, and that includes heart failure, MI, pericardial effusion, and pericarditis. Neurologic complications can include uremia, head bleeds like subdural hematoma, dialysis dementia, and peripheral neuropathy. When it comes to the hematologic system, Anemia and thrombosis are both complications. And that's not even the other common issues like hypotension, bleeding from the access site, a change in mental status, and peritonitis in the patient with peritoneal dialysis. That's enough on background. Let's get to the initial assessment. Obviously, if the patient is sick or toxic, you need to resuscitate. But there are several key parts of the history. First, why are they there? Is it because they're lightheaded? Are they confused? Do they have a fever? And you also need to determine if they're having any symptoms of uremia or because they missed dialysis. Next, you should ask about the cause of ESRD, their current urine production, and if they have their native kidneys. Third is the type of dialysis, their schedule, any missed sessions, and any recent complications from their dialysis. Next is their dry weights and typical vital signs, also baseline labs like hemoglobin levels. Most patients will know what their normal dry weight is, if they reach their dry weights at the end of each session, and what their baseline vital signs and labs are. This can provide a load of information for you. If they don't know this information, but they've been in your ED before, or they come with paperwork, then just take a quick look at those records. Finally is the access site and if there have been any complications or recent manipulations. If they're a peritoneal dialysis patient, you need to know when they perform their exchanges, the dwell times, and also the concentration. Let's finish with the exam. You'll obviously want to focus your exam on why the patient is there, but you also need to check their volume status and ask them if it's at baseline or if it's different. That means checking their extremities and their lungs. Ultrasound can be a big help here to look at their lungs and assess their cardiac function. Next, take a look at the access site. If it's vascular access like a fistula, check for flow with a bruit and a thrill, and look for complications like infection with warmth, tenderness, and erythema, but also look for bleeding or an ulcer. Now, no matter how good the patient looks initially, you do need to perform a neurologic exam, including mental status. Uremia can result in encephalopathy, but this might be only a subtle change in mental status, so ask family members or close contacts if they're altered or if they're a little different from usual. If they're a peritoneal dialysis patient, carefully evaluate for abdominal tenderness or rebound and look at the catheter site for infection and also a hernia. Now, this is just that initial assessment. Hopefully, this gives you a basic approach for the patient with end-stage renal disease on dialysis. I'll have a breakdown of all of the questions and exam considerations in the show notes. Stay tuned for next time when we look at the altered end-stage renal disease patient and what you need to know.
Let's take a little break to hear from one of our sponsors, Metricaid, the experts in complex physician scheduling since 2012. Metricaid's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricaid's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricaid.com/emcases to learn more about how smarter scheduling can work for you. That's metricaid, one word, .com/EMCASES.
All right, so this is Victoria Myers. I am an emergency physician at St. Michael's Hospital in Toronto, and I have the privilege to be part of a EM Cases leadership series where I am interviewing different physician leaders all around the country and the world who have had a huge impact on our specialty. It's a pleasure today for me to introduce and speak to Dr. Catherine Varner to talk about her journey in physician leadership. She is currently an emergency physician at Mount Sinai Hospital in Toronto, and she's also the deputy editor of the Canadian Medical Association Journal. She's a world-renowned physician and researcher, and her research interests are broad, but the most practice-changing parts of her work, from my perspective, are her work on care for pregnant patients in the emergency department. Dr. Varner, thank you so much for joining us. It's an honor to be here with you. And as an early career physician myself, I've really benefited from your work and teaching throughout my residency and into my staffhood.
Thanks so much, Victoria, for having me today. It's a pleasure to be back on EM Cases.
So to start, I think it would be helpful to hear a little bit about your journey as an emergency physician leader, both clinically or in your research role. How did your leadership journey start, and how do you think it's evolved over time?
I think most of us in emergency medicine can relate to a journey that's not one straight line path. And that is certainly true for me. And I think a lot of us go into emergency medicine because we like a lot of different things, a lot of different parts of medicine, a lot of different clinical presentations. And that certainly has been the case in my academic career. And I think what emergency medicine has afforded is some flexibility to both explore academic interests, but also to build what I call like a toolbox of skills that can be applied to both clinical practice and academic work. So I started my career wanting to build that toolbox, and in my early career pursued a master's in clinical epidemiology and applied that to my clinical practice and developed a research career. And then along the way, as part of the journey, realizing I had some gaps and wanting to fill those gaps, I took some time to pursue some additional academic interests that have really facilitated and enabled both my research career as well as some opportunities in leadership, including being a deputy editor at the CMAJ.
And how have you found your experience at the CMAJ as deputy editor? Has it changed throughout your time there, and how did it sort of come to you?
So I've only been there for 2.5 years, and it was a position that I didn't really anticipate in my career. It kind of happened, and I love it when your career kind of takes an unexpected turn, but an unexpected sort of exciting and interesting turn. And it happened because I had developed both an interest and skill set in media, the relationship between media and medicine. And so I did a certificate at the Dalla Lana School of Public Health at the University of Toronto that was to build the media experience of people working in healthcare and relationships between media and healthcare and research. And so I did this journalism program where you essentially become a journalist for a year. And I was introduced through the CMAJ from the publishing side as a journalist and worked with them in doing articles during the pandemic. And then that created this relationship and then ultimately an opportunity to become a deputy editor at CMAJ. And it's been an amazing opportunity to be on the other side of scientific publishing. So not as an author, but as an editor, and helping people get their ideas out there or their clinical experiences out there in the forms of case reports or commentaries, analyses, those types of papers, and facilitating in that way.
It's really amazing how sometimes the opportunities that we don't plan for come to us and help us grow and develop skills and sort of find us rather than us seeking them out.
Absolutely.
I hear a lot from people that being open to opportunities and having varying interests, which it sounds like you did in pursuing your journalism pathway, sort of can sometimes lead to the positions in their career that they didn't necessarily anticipate. Do you think it's been helpful for your growth as a leader to have a role outside of your clinical work, sort of outside of your clinical home, which is Mount Sinai, at the CMAJ?
I think it came at the perfect time, in that I was at the end of my early career, and I was, I think, seeking, whether I realized it or not, some leadership opportunities, but I wasn't, and now reflecting on it, I'm not sure I had the confidence to seek those in my own hospital and clinical environment, because it's at times hard to do that where you quote unquote grow up. People see you as a trainee. People see you as having maybe just come back from maternity leave, and they don't often think of you as that person who should step into a leadership role. And I'm not sure I saw myself as ready to step into some of those hospital level leadership roles. And so going into a new environment, I think, gives you an opportunity to be a bit more confident for people whom you've not worked with before, establish yourself as a leader in that space, and then also learn from an entirely different organizational structure that you can grow from. And I think that's been some of the most interesting learning at the CMHA, because it's not an acute care hospital. They don't work with sort of the same time pressures or same acuity, certainly. And so it gives you some time to sort of think about strategy, think about organizational structure. And I think that has been really eye-opening for me to bring back to my role in research. So as Deputy Director of the Schwartz-Reisman Emergency Medicine Institute at Mount Sinai, but also to my clinical practice and to my clinical group. So it came at, I think, the perfect time to take a step outside of where I had grown up, so to speak.
I think that is a great pearl. So what I'm hearing you say is that, I guess in the first part of our discussion, talking about pursuing varying interests, which really sort of applies to probably most of us as emergency physicians, which is part of why we went into the specialty, can lead to unexpected opportunities. And then I really can resonate with your point of developing leadership skills and in roles that are outside of your typical working environment where you trained. People have a hard time necessarily always seeing you as the grown-up leader that you want to be and are. And also being a leader in an environment that is not an acute care hospital gives you varied and incredible skills to bring back potentially to your own clinical practice as well as your hospital. It sort of reminds me of how my mom still thinks that I'm 12 years old, despite me having a medical degree, giving her medical advice for which she is non-medical. She has a hard time seeing me as a full grown-up physician. And I think that probably happens to us to a far lesser degree in the places that we train because people have known us since our first day of residency.
And now that I'm, well into my mid-career, I have to remind myself of my own bias in that way, because I often will think of people who were trainees in their early career and are now very much well into their early career years and ready to take on leadership roles. And so it has been a great reminder to me to make sure that we're giving our colleagues the experiences and opportunities that they need to continue their trajectory through their early academic careers.
Amazing. That's also a great pearl to remember our own biases around our very junior staff who we've seen sort of go through all of their stages of training. Let's kind of switch gears a little bit and talk about balancing your work and your life. You're an incredibly accomplished physician and partner and mother. And I'm just curious if you have sort of an approach to that balance and how you make it work for you in your life, which I think is different probably for everybody.
I would say it's such an individual journey. And I remember wanting, certainly as a medical student, for people who were ahead of me to provide that perfect map, that perfect roadmap, the solutions for how to make that work-life balance really click. And as I've gone along, I realized that it just is such an individual process for you and your family to figure out, honestly, sometimes it feels like almost on a month-by-month basis to figure out how to make the schedules work. So I'm married to another academic physician who's a surgeon, and we have a very, I would say, unique approach to our work-life balance and trying to make sure that we are available to our 3 children who are all school age. They're all elementary school age and need us a lot. And want to be a part of our lives. And we're so fortunate that is the case at this stage, because I think when they become teenagers, maybe it's less so, and we're just really embracing it. But it's such an individual decision, and one that we, reassess really every schedule, almost every time we're doing a schedule to make sure that what we're doing is working. I work almost exclusively night shifts, and I know that's not forever. But it has been for the last decade since we've had kids. And that's because I know that I'm able to facilitate one of us being available if one of the kids gets sick. It is one of those things that people sort of raise their eyebrows. Well, why do you do it that way? And I'm like, well, it works for us. And it has for a long time. So, and in some ways, it's actually facilitated my academic career because I'm quite available in the daytime and flexible to make academic meetings, to work on papers, to have quiet space at home to write. And so it works for us, but it certainly wouldn't work for everyone.
So it sounds like everyone, your approach to balance is individual. And sort of for everyone listening, I think it needs to be individual to the way that your life is structured, to who you have in your life for supports and who you have in your life that you do support. And despite maybe doing all nights is not the most classic approach to work-life balance. But if you find that it works for you and works for your ability to pursue your academic career as well as be present as a parent, that is really what matters kind of within your family. And that being adaptable sounds really important too, that being able to sort of change up or try different strategies with your schedule depending on the month is important.
Being a parent of really young kids in the pandemic, I think that's what we learned, was how to be really adaptable. And I think our kids also learned to be quite adaptable in that. And I would say, it was not uncommon in that it was early crazy times when our kids were online. I had a kindergartner who was doing online school, which was crazy. Their teacher seeing this sort of person asleep in the background on the couch and sort of wondering what's going on. Well, that's how we made it work, was night shifts and in online school. And so, I think any time going forward is probably better than that time. And I think that was a learning experience for everyone, but adaptable, I think, is a great word.
Online school during COVID with 2 academic physicians sounds incredibly challenging.
It was very challenging. But we had a great group, at Sinai who supported one another like family. And I also think in those pandemic times, clinical groups really, it meant a lot when they were supportive of one another. In the same way, I think that marriages either thrived or did not thrive during that time. I think academic or clinical groups had the same sort of situation where either they supported each other and grew together, or it became very difficult through the course of the pandemic.
That's another really good point about balancing work and life, is that your work family is an important piece of that. And when maybe thinking about where to work or where people work, having a work family that helps you with your work-life balance and supports you in times of departmental stress or personal stress or societal stress can really make a big difference in your own ability to balance when you're not overcoming obstacles with your work life and work family, but instead you're being supported by them.
And I think in emergency medicine, that's a unique relationship. We are a 24-hour-a-day operation where if someone is not available to work, we have to have somebody immediately available to fill that space. And so I think by virtue of that, we become intimately aware of one another's personal lives. Who's got gastro? Who's pregnant? Who's, about to go out of town? When the flight is. Like, we become, well aware of what's going on in each other's lives. And I think supporting each other, I would hope, is inherent in that. And we certainly found that in our group. And I think that's what I value so much about my colleagues in emergency medicine, is that we're not just people who work side by side, but we do, I think, intuitively support one another in ways that I think are unique to our work environment.
That about wraps up our discussion. Thank you so much for joining us today. We had a great talk about your leadership journey and how leading in an environment that is different from your clinical practice can enhance growth and lead to new skills that you can bring back to your clinical environment and beyond. And also how balancing work and life is unique and personal to each person, and you need to be able to find what works for you, and also consider your own work family as an important role within balancing work and life. Dr. Werner, it's been wonderful having you. Thank you so much for joining us, and we hope to see you again on EM Cases.
Thanks so much, Victoria.
Thanks so much to the amazing contributors to this EM Quick Hits, Dr. Varner, Dr. Myers, Dr. Long, Dr. Seguin, Dr. Stefan, Dr. MacArthur, and Dr. Bogosh. I hope you learned a little something about tick-borne illnesses like babybiosis, and that it needs a separate test and the treatment is similar to malaria treatment. A bit about how skin glue is a reasonable alternative to sutures and faster for nail bed repair, and that discarding the nail is acceptable as opposed to suturing it back in. And I added that when it comes to indications for removal of the nail to repair the nail bed in the first place, consider removing that nail if there's a significantly displaced phalanx fracture, if the nail plate is obviously mobile, lifted, or split, or if the nail margins are obviously disrupted. Remember that intact margins means you don't need to remove the nail to fix that nail bed. Remember that intact margins generally means you don't need to remove the nail to fix that nail bed. We learned about a simple approach to pediatric ECGs and what normal looks like across ages. We'll have a quick access summary in the show notes with ECG examples, and I think that would be really useful for you to review and to save on your phone to have on shift. We delved into how best to do closed-loop communication, a basic approach to the patient with end-stage renal disease on dialysis, and we got some inspiring tips on leadership and career choices. If you like what you hear, please consider a donation, small or large, by heading to emergencymedicinecases.com and just hitting the red donate button. We make it quick and easy to help us make you better emergency providers. So until next time, take it easy.